Good morning, and thank you for attending our Grand Round series today. My name is Rahul, one of the Chief Cardiology Fellows here. I'm pleased to introduce to you our speaker, Dr. D'Agostino. Today's lecture is part of Natalie and Jack Congdon Visiting Scholar lecture series. A little bit about the lectureship. In 2010, Natalie and Jack Congdon established the Natalie and Jack Congdon Visiting Scholar in Cardiology, which enables the VCU Pauley Heart Center to attract a number of talented cardiologists. After his service in the Army, Jack helped build the family trucking business of Old Dominion Freight Line Inc. and Old Dominion Truck Leasing Inc. Jack was a proud supporter of the Massey Cancer Center and the Pauley Heart Center. Jack and Natalie unfortunately passed away 10 years ago. They had 3 children, and their son John continues to support the Pauley Heart Center as a donor and advisory board member. Dr. D'Agostino is a professor of biostatistics and data science at the Wake Forest University School of Medicine, where he has been on the faculty since 1994. He currently is the Director of Biostatistics Shared Resource for the Comprehensive Cancer Center at Wake Forest and the Director of Graduate Program in Clinical Research Management at Wake Forest. He has served as the Principal Investigator, Co-Director, Lead Statistician for several large coordinating centers in disease areas including cancer, cardiovascular disease, diabetes, and stroke. He's a fellow of the American Statistical Association and has over 380 peer-reviewed publications in the areas of both clinical research and statistical methodology. We are grateful for Dr. D'Agostino's expertise on this topic and look forward to learning from him. At the end of the lecture, we will leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for our Grand Rounds conference series. As always, to claim credit for today's session, text the code shown at the beginning and at the end of this presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Winston. I will now head over to Dr. D'Agostino. Thank you, sir.
Okay. Well, good morning. Thank you for having me. And again, thank you for the invitation. So today, my presentation is going to be on an overview of Mendelian randomization in clinical research studies. And before I begin, I have just to go through some disclosures that I have served as a consultant recently with these 5 different companies, although it has no direct relationship to what I'm presenting today. And I also like to take a moment to thank several people, but I'm highlighting a few, but there's obviously more to possibly be thanked. But Greg Hundley, thank you for inviting me to present today. Greg and I have worked together for over 20 years and was on the phone with him and said that there's an opportunity that I'm going to be coming up this week for a meeting for another project. And he said, oh, you should come and give the Grand Rounds. And he said, why don't you talk about Mendelian randomization? So I want to make that clear that I will present hopefully a nice overview of it, but this is not the area that I'm most expert in. So if somebody in the room raises their hands that I'm an expert in Mendelian randomization, I'd be happy to listen to your opinions as well. But I am someone who can speak on the topic, but not a full expert. Amy Ladd, I want to always thank her because and there's a lot of people, but Amy, I think in particular, keeps the machine running very well everywhere, and I just appreciate all her work, and Shannon for helping coordinate the details of this meeting, and as was pointing out, the Natalie and Jack Congdon family, because they are the ones who support this whole series. And before I begin, I also like to take a moment just to thank my family and God as well, because it's their love and support that has helped me get anywhere I've been able to achieve in my own research career. So the learning objectives, and this was on the first slide, is to compare and contrast Mendelian randomization methods to traditional randomized clinical trials and observational study methods. So my background is in mathematics, statistics. I do a lot of applied research work with cardiologists and oncologists in a lot of clinical fields, but my actual training is in the statistics side. So this is going to be a study or a presentation more on how does different statistical methods are implemented in clinical research studies, in particular, this idea of a Mendelian randomization study, randomized clinical trial, and observational study. And at the end of this presentation, hopefully you'll be able to describe the specific features or differences among these different trial designs, as well as understand the concept called instrumental variables, which is a concept that is used pretty well in the Mendelian randomization setting. So actually, for those of you who have ever already, before you begin the talk, know these terms, that instrumental variable concept is one that's often a struggle to figure out what can be an instrument. And you'll see that this is one of the few settings that I think it actually makes a lot of sense. And so this is something that we'll talk about. So what's the, the motivation? Well, in research, some days, and this could be considered a little bit cynical view of the world, but it seems like every day we're hearing about some new risk factor or some new exposure that can cause some disease in some people. And I know it was kind of funny is that this was a cartoon from that was published in the Lancet back in 2004, and they called it from the New England Journal of Panic-Inducing Gobbledygook. And I was thinking there was probably them throwing some I don't know, making fun of their competitor journal, because I thought it was funny that the Lancet would be calling this New England Journal of. But the point is, it is true that we do see in prominent journals like JAMA and Lancet, New England Journal, almost every month, some implication of some exposure or intervention or risk factor that could possibly be linked to a disease in a certain group of people. And then you start to wonder, is it just every month we're going to hear something new? How do we know what to believe? What is when can we sort of use this word cause? That's the sort of like the key word here. It's not just associated, but cause. And that's what's the motivation in some ways of this topic and talk. So an outline, let me pause for a second. Are you all hearing me fine? Okay, good. And online, if they weren't hearing me, I would have known that. Okay, you hear me. Okay, good. So, all right. I see the number 45, but I say this because I was telling the gentleman up there, just Tuesday, we had our grand rounds at Wake Forest. I came in, they had food, they ran out of food, so I said, I'll go back to my office. And so I sat down, turned on the thing, and audio was not working. I mean, the whole thing was a disaster. And we're all like chatting, we can't hear you. And they said, we can't stop now. It's like, okay. So I feel like, it's like so I just wanted to make sure before but he confirmed we're good. So this is good. All right. So background, the motivation linking to randomized clinical trials, which is, you'll see a sense it's the gold standard for doing clinical research. So why is that the case? Why do we do randomized clinical trials when possible? Talk then about what are some of the challenges when we can't do randomized clinical trials, when we have to use something called an observational study, and that will motivate a solution to the problem, or at least a proposed solution, which is this Mendelian randomization approach. When we get into that, I'll try to give you some definitions, talk about the advantages and challenges, give you an example from the published literature and a discussion. So, and I'll give you the key point at the beginning is, I think Mendelian randomization is a useful tool that can be used in clinical research studies in cardiology and a lot of other diseases, but it's not really going to solve all the problems. And it's not really the answer to causal inference in exposures. It's just another approach that can give us further evidence along a pathway to understanding science, understanding relationships. But you'll see pretty quickly that it's flawed, as well as all methods are flawed. But the idea is, if you have enough, good approaches that you're using, when you combine them, you can often make good inference. And so this is a tool I would certainly endorse you to, when it's usable, to use it, but I wouldn't want you to walk away thinking this is what's going to replace all randomized trials. So this is how I do observational research. No, that's not the answer. It's just another tool along the path. Okay, so let's start with an intuition about clinical research. And again, I apologize because this is going to be a talk about trials and thinking. It's not specifically about a cardiologic phenomenon. It's more like about research designs issues. So a randomized clinical trial is considered the gold standard in statistical medical research for determining if a treated group is different from a control group. The idea is we set up on a pedestal, like if we can do a randomized clinical trial, we can determine, if statin use is in fact, better than people not using statin for lowering lipid values. We sort of say, if we use this mechanism of randomized clinical trial, that's how we can tell if some intervention works. So why do we randomize, or why do we believe this approach might work? Well, fundamentally, what we're thinking and doing, we're saying, when I gather individuals, identify a population of individuals who I wish to study a question on, and I draw from that group of individuals a sample, some people to study. If I randomly assign, if I use this process of randomization to assign a treatment to units in a random fashion, and I use the word unit because it doesn't always have to be humans. It could be any number of, it could be, plots of land, it could be animals, it could be, plants. Bottom line is, if I can assign randomly the treatments I'm trying to study, the idea would be the things that each of these individual units had, their background characteristics, the things they walked into the room with. So you all walked into the room with an age. You all walked in the room with a certain blood pressure. You walked in the room with whether or not you had diabetes or not. All these things that you all had before you came into this room exist, okay? If I were to randomly assign some of you to get a new treatment and others of you to get an existing treatment, on average, this is where statistical theory comes in, on average, the characteristics that differentiate you at the beginning would be balanced. On average, the men and the women might have been randomly and equally, more or less, assigned to the different treatments. The age groups would have been more or less randomly assigned. And it's this idea that the things I measure on you, like if I know you're diabetic or not, that hopefully would be balanced, but even things I didn't know about you would be being balanced because I'm randomly assigning you. So like the idea is this: if I got a room of 10,000 people and put 5,000 in one room group and 5,000 in the other, and I did that randomly, on average, the things that we knew about those people at the beginning would be equally or comparably distributed in the two groups. And if that balance exists, so then that's the assumption, randomization will create balance. If that balance exists, so Greg and I sometimes talk about this, if I did randomly assign you guys into two groups and by chance put everyone over 50 on the right side of the room and everyone under 50 on the left side of the group, you wouldn't believe the randomization worked in the sense that, well, that's age is totally imbalanced. So we do have to always say that this approach, in theory, is what we want to have happen, but you actually have to look to see what happened. But the point is, if balance exists through randomization, then I hand some of the people a new intervention and the other people a different intervention. We can follow the people and say, hey, when we get you 6 weeks from now and measure a characteristic, if it's different, it's probably due, most likely due, even probably caused by the treatment and not by all the other things that you had beforehand. So that's the thinking. Did it work? The assessment of the success of randomization and balancing the characteristics are things that you could do at the moment you randomize. So that's part of the main intuition. I don't at the moment I assign individuals into groups, that's the moment you would assess balance. You don't assess balance after you give the treatment, because once you hand somebody an intervention, well, the intervention can start impacting characteristics. It's not going to make you get older or younger, but it could, change your blood pressure immediately. You just at the moment I give you the drug, even if it's a statin, it could impact your blood pressure. So we assess balance immediately. And this is, again, an important theoretical concept, but I think it's important practically speaking. We don't say only certain things should get balanced. We really say everything should, and it keeps you safe, because if you only said only important things get balanced, then you're in 3 weeks when someone tells you something new is important, you say, oh my gosh, I didn't even look at that because I didn't know it was important. We always are learning new things are important. And the idea of randomization, why it's so nice, and this is why other techniques struggle, is because the process sort of protects you against all variables being balanced. Okay, so this is a little bit the intuition. Okay, so that's a randomized clinical trial. And that's what, if we could do, we would love to do. But what about when we can't do that? Observational research, it's enormous in many medical fields, cardiology in particular, but lots of other medical fields, cancer and others. What if I can't put you all in a room, break you into two groups of 5,000 and hand you a new drug? That's just not feasible. I, as an investigator, cannot have any control over what drug you're going to take or the treatment you're going to receive. Now, why would that happen? Well, sometimes, you can talk about it's logistical, ethical reasons. I want to know if, the classic example, I want to know if smoking is bad for you. Well, how am I going to really, assign human beings to start smoking or not smoking. Like I want to know if, high alcohol consumption is good or bad for you. How am I really going to run a trial on, this group is going to drink 6 bottles of beer a day and this group's not. You want to understand what smoking and alcohol would do to you, but I can't do it. Even in cancer research and other things, it gets to a point where can I really randomly assign someone to get a particular new or innovative surgical procedure or not? Will I really go into the OR not knowing what you're about to do to me? Would the doctor really agree to say, well, when the patient shows up, I'll look at the card and decide to give them surgical procedure A or B? That's kind of challenging, but we still want to know if surgical procedure A or B work, but I can't really randomize. And other times, because, if you think about all the wealth of data we're collecting, you could say already data is being collected in the form of research studies that can help inform us about other drugs. We just didn't randomize them. So you have this large cohort study. You've been looking at patients over time. And by the way, you're finding out if patients are taking an ACE inhibitor as part of their treatment pattern for blood pressure. They were just part of the large MESA study, or they started part of the Framingham Heart Study. They didn't get assigned an ACE inhibitor as part of that research study, but we know these patients took it, these patients didn't. Couldn't we see what ACE inhibitors do on outcomes in this study? We didn't randomize, but we have all this data. So that's the setting where randomization is not going to happen, but we still want to understand what's going on. Now, this is a point where I want to pause because as I began to dive more into what is the Mendelian randomization, this is an important differentiator. There's different kinds of observational studies. So some of them do resemble really closely a randomized clinical trial. It's just that we didn't randomize. So I want to examine if an intervention, like maybe a drug like statin or surgical approach, carotid artery stenting, I want to look at this to determine what impact that intervention has on an outcome: mortality, heart attack, stroke. Okay, so that intervention is, in a traditional sense, a pharmacologic agent, a statin, a procedure, a surgical procedure. Other times in observational research, we want to look at an exposure, which is not exactly an intervention. Vitamin D levels. How much vitamin D does a person have in their system? How much alcohol do they consume? What is their CRP level? These are like measured continuous variables, but I'm not really thinking them at the same way as I'm giving you a statin, but I want to, people with high or low vitamin D levels. So that's a good question, right? What impact does that exposure have on outcomes? Mortality. So we have the same set of outcomes, but even the framework of the question is slightly different. It's not like statin users, yes, no. It's, high vitamin D, people with high levels of vitamin D versus low. And at times, the exposure could also be an intervention. So I could give you vitamin D supplements, yes or no. But it could also be just simply the level you have as an exposure, and I'm not actually intervening. Okay, so I don't want to make it clear because Mendelian randomization studies really focus on the exposure types of studies. And you'll see that in a few seconds why that's the case. So just to give a couple examples, so this of observational research studies and publications. So this paper I was part of that came out in 2016 in The Lancet was about looking at transcatheter aortic valve replacement versus surgical valve replacement in intermediate risk patients. And the thought was, or the idea was that these patients came from an observational study, the SAPIEN-3 study. Patients were not randomized to get these different procedures, yet we wanted to understand what was happening when they got procedure A or B. And in this setting, we use something called propensity scores to basically try to compare the groups. I bring out this paper because I was part of this paper, but it's had already over 1,000 citations from this one paper in like less than 8 years or something. And it's because it was a major cardiovascular trial in some ways, but it wasn't randomized. So the idea that, and the FDA looked at this data and it was using it as part of some of what was going on and understanding different procedures. So it's just trying to say that this was an important paper because it came into a big journal, but also sort of said, hey, we can do observational research, publish it in a journal, and actually have regulatory decisions have something to be impacted by it. This paper here is a more recent paper. in 2018. But what it's just trying to illustrate is a question: vitamin D and breast cancer, systematic review and meta-analysis of observational studies. So what this group of authors did is basically went out and pulled data from all different observational studies, like where vitamin D was measured and whether or not, incidence of breast cancer occurred, and tried to make some understanding about, is there some, in this case, relationship between a deficiency in vitamin D and maybe the occurrence of breast cancer. But this study was just a gathering of information. So this second study in particular is more in line with what Mendelian randomization studies would try to help us with. The first study, it wouldn't. Okay, I'll just say, so a transcatheter, that's not an easy problem that you would think Mendelian randomization. Okay, so challenges. In those examples and all of observational research, there could have been considerable differences in the characteristics, risk factors between the treated and control groups. The patients, the breast cancer patients, people who could have gotten breast cancer, who were having high and low levels of vitamin D, they could have been older or younger. They could have been had more stress, less stress. They could have had more social determinants of health, good or bad in either group. Okay, so these characteristics, which can be things like demographic variables, metabolic variables, cholesterol, blood pressure, behavioral characteristics, do they smoke, do they exercise, and other characteristics that come out of quality of life, social support, psychosocial stress. All of these things could have been very different between, in the first example, patients who got surgical procedure A and B before they started. The patients who chose the more innovative procedure might have had a lot more access to a lot more information. But patients who were taking vitamin D supplements or had higher vitamin D might have had access to things. And if these differences exist, then, and we found out that some of these things, like maybe, tobacco use could be associated with getting breast cancer. So people who have low vitamin D also seem to smoke. Well, I want to say vitamin D is why they're getting breast cancer. Well, probably not. Maybe it's smoking. And it's just and so that's the idea of when that happens, when simultaneous variables are associated with both maybe the treatment you receive, but also the outcome, then the impact of the treatment exposure on the outcome can be confounded. So that whole concept of confounding is embedded in here. Okay. So just basically a visual. So you have some treatment or exposure. And I wanted to differentiate because, this would be like getting the different types of surgical procedures or treatments. And the exposures would be, high and low levels of vitamin D. You set up that here. I'd like to understand what that does, how that impacts an outcome. But we have things that we measured and unmeasured that we might think of confounding. And so an example would be transcatheter aortic valve replacement versus surgical valve replacement, high vitamin D versus low. Mortality or breast cancer could be an outcome we're measuring, because that's what was the primary outcome in that first study was like mortality or breast cancer incidence. But, age, blood pressure, stress, we went and measured those on those individuals. And those things actually could have impacted your vitamin D levels, could have impacted whether or not you got the surgical procedure. Also, definitely, that's why the arrow is pointing out, they also could definitely impact your mortality and your breast cancer outcome. And then sometimes, like, we didn't always properly or necessarily measure all pre-existing conditions. So we might not even know if the patients were diabetic because we didn't do a, oral glucose tolerance test. We just simply maybe had a self-report, but we don't really know if they had diabetes. You don't know. So as an unmeasured confounder, and it also could, if people with diabetes could actually, you could make an argument, you don't know for sure, but you could have chosen one of the two procedures more than the other, or diabetes itself could have some impact on your level of vitamin D, and it certainly could have some impact on mortality and potentially breast cancer. So that's the idea. These are confounders. So all the buildup to a clinical trial, research, a randomized clinical trial, observational studies. You want to do randomized, you have observational research. We have a problem or challenge, and now someone said, hey, maybe there's something we can do. Mendelian randomization is an approach that primarily tries to confront the challenge in observational studies that examine exposures. That second scenario, the vitamin D scenario, not interventions. Other approaches in that paper, that transcatheter paper, things like propensity scores. In cardiology, there are other about things like this. That's like an analytic strategy that is more appropriate for interventional challenges. But Mendelian randomization is something that can really head on address the challenges we might face with issues in exposure studies. Okay, so what is a random? So in a randomized clinical trial, we have a population, we get a sample, we do randomization, confounders should be balanced between the two groups. So we have an intervention and a control group, an exposure group, a non-exposure group, and we compare the outcomes. In Mendelian randomization, and sometimes I'm going to use the letters MR, and sometimes in the research world, you hear people just say MR, and that's what they're, in the context of this talk, MR is Mendelian randomization. Okay. It's a statistical approach that uses genetic information to help us understand the relationship between an exposure and an outcome. And it's called Mendelian randomization because it uses a couple of Mendel's laws of inheritance. Now, I will step back and say, those of you who are on the Zoom call, those of you in the room, I am not a geneticist by training. I'm a statistician. I do statistical analyses. And so this part here, I'm reading definitions, but I don't want to claim that I'm, the statistical geneticist. So if I say this slightly, I'm saying it as the best I can, and I believe it's correct. But again, if someone said, well, that's not totally precise. I know this because sometimes I sit in the room and someone says something statistical and say, well, that's not exactly right. So I don't want to, I believe this is the way to say it, but the law of segregation is during gamete formation, the alleles for each gene segregate from each other so that each gamete, see, I don't even say the word enough to know if I should be saying a gamete. That's that you could just say, oh, he's such an amateur, he's speaking, pronouncing the words silly. Carries only, I do know how to say allele, only one allele for each gene. This is assumed to happen randomly. So basically, the bottom line is you have two parents, and the allele that's transmitted is considered to happen randomly. At conception, all the information, genetic code, if you wish, from the mother and the father are basically brought together at the time of conception. And the allele that comes from me on each, there's a choice, and it's randomly happening that this one's coming forward from me, this one's coming forward. And the idea, so the alleles for each gene segregate from each other so that each gamete carries only one allele for each gene, and independent assortment. Alleles for separate traits, the allele that predicts my eye color, the alleles that will predict my risk for diabetes, the alleles that predict my risk for high-low vitamin D, they are different traits. They're transmitted independently of each other. So I'm going to just say, again, as not even a genetic expert, you sometimes wonder if these are really true assumptions. The more we do more genetic research, is it really true that alleles separated for traits are transmitted independently? Or don't we learn that certain things do co-together? So I'm just going to say this is a step back and say, that assumption to say that the gene that predisposes you to high alcohol consumption and the gene that predisposes you to maybe tobacco use, do they really operate differently? It seems like that. Lots of evidence, maybe they don't, but who knows? All I'm just trying to say, but these are the assumptions in Mendel's laws of inheritance. So this here I took from this Making Sense of Mendelian Randomization and its use in public health research. This is the reference to it because it was a nice little visual illustration. So what happens? Pretend you want to look at if BMI and exposure, they're going to call that now, level of BMI, that's my vitamin D level, that's my exposure. If it has an impact on raising systolic blood pressure in a causal way. They want to know, does high BMI cause high systolic blood pressure? So people in the general population have many differences that could confound the relationship between BMI and hypertension. So the bottom line is everybody has a different shape and color, and these things in the general population, that all the different features of these people might be why BMI is not the full cause of systolic blood pressure, something else could be. Now, however, these differences should not affect their genetic propensity for having high or low BMI. So if there is a gene identified that is related to your propensity to have high BMI or not, then you would have, people who have the high level of this gene all the way down to the low, and say, oh, look, and this is the theory, oh, look, in each group, they all look alike, because it's balancing all the things that look different generally. Well, there's no reason why the people with the gene at the high level should look different from the gene at the low level. Now, if the people with the gene for, the high, very high propensity for high BMI, actually, you go out and measure the BMI and it's true. You actually confirm, okay, this gene is supposed to make me at risk for having a high BMI. I go out and say, you have a high risk gene for that high BMI. Oh, you actually have a high BMI. You, on the other hand, someone has the pink gene, which is, low risk for high BMI. You go out and measure, and oh, look, their BMI is low. So this is saying if, in fact, the genetic information is well associated with the measured exposure, then, here's the big step, then the propensity for high BMI, not actually BMI anymore, but just what gene group you have, this is the big jump. Rather than measuring BMI and seeing how that's related to blood pressure, let's just measure your genetic information that says, oh, we're going to put all the people who have the high propensity for the genetic formula that says that they should have high BMI and look at their hypertension, and the people with low, and if they're, and the idea here is this supposed to show, and it probably didn't come out well when I moved the slide, but it's a very strong relationship, that the actual exposure to the gene should look really linear, and maybe now the gene to the other outcome, it's still linear, but maybe not quite as strong. But the idea is, if on average, people with higher genetic propensities towards a high BMI, their gene tells you that you're dark purple, if they have a higher rate of hypertension, then we have evidence, and this is where it comes, that BMI causally increases hypertension risk as a genetic propensity can't be affected by confounders of hypertension itself. You don't get your gene that puts you at risk for BMI because you're hypertensive when you're 50 years old, right? The gene that you got came to you at conception before you even were born. You get hypertension many years later. So there's no way that, that outcome could have impacted your thing that happened at birth. And so this is what it's all about. So you have the population of interest, you take the sample, now you say there's a random allocation of alleles, independent assortment. Some people have the allele, some people don't have, the thing that puts you at risk or not, that should be random. And that should, since it's happening at birth, happening at conception, independent of everything, that should balance people on everything else. And now I should be able to compare the outcomes. So it's what I think is the clever and fascinating thing is, in the end, you're not actually going to measure BMI in that example. You don't. You just measure the gene for BMI and hypertension, but you had to make a whole bunch of work to say that gene for BMI is predictive of BMI, and therefore I can look at the gene and hypertension and understand. So now, one of the concepts is the random allotment happens at birth, but the outcome may be many years later. And I'm going to say this at the point I'm going to come back to a couple of times. This is one of the major challenges. So the genetics world just say, well, who cares? I say, well, I don't care, because, you want to say that this Mendelian randomization is like a randomized clinical trial. But it'd be like I say, guys, I'm going to give a randomized clinical trial. I'm going to start you on statin today, and I'm going to measure you 40 years from now to see what happens. It's like, are you kidding? I mean, like, how would I trust that in 40 years, any of the things that happened when I started are still really going to be the predominant reason why it still works? But that's the major assumption. At baseline, inception, everything was balanced. And we're just going to wait for 50 years and see what happens. And they say, well, that's true. Everything was balanced when the dice were first rolled, but there's a lot of other movement going on. And I think that's one of the things we have to just consider. That time between, quote, the randomization and the measurement is not the same as a randomized clinical trial. So they keep wanting to say this is like no, we would never design a trial where we actually randomize today and wait 50 years for the outcome and think that it all would just work. You know what I mean? So I'm just letting you know that's an intuitive thing as a statistician. This is something you got to worry about a little bit. This picture also came from the American Journal of Epidemiology back in 2006. But I thought it was a nice way to basically show the common elements of a trial and Mendelian randomization. So the intent to treat, you randomly assign a treatment. There's compliance. People may or may not take the treatment. Some people actually get the treatment, and the treatment has an effect, and you measure the outcome, and there's still some potential impact of unmeasured confounders. You randomly allocate allele at conception. There's penetrance and functionality. So this is the idea. Like, so just because you have a gene, we learn they don't all become activated exactly. This is the whole idea of epigenetics, like genes come to me at birth, but they don't all on every human being operate exactly the same. There's sometimes a trigger that makes that gene become functional and so forth. But then the bottom line is you get an intermediate phenotype. This is the idea. You have the gene, and then you observe that the people with the gene, have higher BMI. Then you say, okay, what if that intermediate effect now maybe leads to hypertension, and there's still potentially, is there the idea of the confounders can impact this, but it shouldn't have impacted basically the random assignment. Okay, so now we're at the point where we're hopefully beginning to understand the general idea of what Mendelian randomization is going to be all about. At the time of randomization in a Mendelian randomization study, confounders should be balanced. What they're saying is when conception occurs, there's no reason to think that if a group of people with the BMI gene and not the BMI gene would be different. They're not going to be different in age. They're all at conception. They're not going to, all the things that were when the randomization happened. There's no reason to think there's such systematic difference. And it addresses the fundamental challenge of observational research, which is assuming other confounders exist and are different. Any treatment or exposure effect we see could be due to the confounders. But if the confounders are balanced, similar in both groups at the time of randomization, then differences in outcomes can be considered not due to them. So that's the first thing. Hey, we say when we think of, and the idea is they're thinking nature is doing the randomization for you. Okay, that's what it comes down to, right? Who's doing the randomization? Well, in a clinical research trial, Greg or somebody's going to say, okay, I'm going to set up an algorithm and you're going to randomly assign. God is doing the randomization in these studies, whether or not you have or you don't have the gene. Okay. Advantage 2 of Mendelian randomization, direction of relationship is known. And this is actually an important one. Reverse causation, which is always a concern in observational research. Did hypertension actually cause me to get overweight, or did being overweight cause me to get hypertension? What causes what? The genetic trait, by the way we're defining the study, has to come first. The outcome is something that's not even going to be possible to even measure to much later. So therefore, the issue of the possible reverse causality is avoided. There's no chance that, now going back to I'm going to switch, the picture I showed was the BMI hypertension, but I'm going to switch back to the vitamin D breast cancer for the rest of the talk illustration. There's no chance that someone developing breast cancer at the age of 40 caused the gene to give you a higher or lower risk of vitamin D having ability to have high and low vitamin D levels in your system at conception could have been caused by an event that happened later. So this is a very nice feature, because if you think about in a lot of observational research, there is always we have all these interesting variables of what's causing what and what direction, and you don't have to worry about it in a Mendelian randomization. Now, but there are some challenges. Do we really believe that how alleles are distributed in the world are random? So that first assumption, is it really true that this random assignment of the allele being the thing that tells you that you're a high or low risk for the trait? The issue is sometimes referred to, if you see this word, population stratification, which is when non-random mating between groups due to physical separation, maybe the continents, is followed by genetic drift of allele frequencies in each group. Basically, they're saying populations didn't just, we really didn't just, as human beings, randomly mate with everybody, and therefore the alleles were randomly. No, there are people lived closer together, and therefore they shared a lot of characteristics, and then they mated, and then they had children, and those alleles are not being sort of mixed with, and the idea is the different continents, the African continent, the European continent, South America, North America, these continents of individuals could allow for the genetics to say that these really are not random, that maybe within the continent, but not across the continents. And I would argue, but even at a local level within a family, so that's maybe where it'll be random. If I have 6 children, actually, so maybe they all have a random allele, but because now we have the same starting point, and what happened could be random. But I don't think that random people mate together to have offspring. So I think that's but again, that's an assumption. Maybe in the animal kingdom that works, but I don't know. And so is it possible people who have children together may share some genetic factors? And this may not be purely random. And we know it's true, actually, because a lot of diseases in Israel, there's certain genetic diseases that predominantly affect people of Jewish ancestry, and it's because there's evidence that individuals of that ancestry have, selectively, mated. I'll use the word mated, but whatever, reproduced together, and then certain genetic diseases. Gaucher's disease and other things have happened more predominantly, and it's because it's not a random mating process. And I think that's, so again, the high level assumption in Mendelian randomization is, well, that doesn't really happen often or doesn't really change much, but just remember it probably does. The second challenge is, I think it's this, how long after randomization, I began to allude to this, in a randomized trial, would you trust results? And when there's a one-time randomization at conception, at that point, everything is balanced. But 50 years later, really? I mean, why? You know what I mean? An entire life of experiences have happened. So is that balance, which is the fundamental principle of randomized clinical trials at birth, enough to protect you for a measurement that's happening so later? Isn't it possible that when the window of time is short, we think that the differences are not going to be due to other features? But the longer the window goes, again, genetic randomization happened, and I believe, if you measure something at age 2, sure, that is not going to be messed up by the world. But 50 years of the person living their life gives us a lot of variability that can have that life interfering. Okay. And then finally, challenge 3, at conception, all genetic code is transmitted. So that's what they say that, right? At conception, all the genetic code, not just some. This implies that thousands, essentially, everyone said, I'm going to do my Mendelian randomization on vitamin D because that's what I care about. Well, everything happened at baseline. It's not just that. So there's all these Mendelian randomizations going on. And there may be a gene that predisposes a person to higher vitamin D level, which we wish to study, to determine, breast cancer rates. But there may be a second gene that predisposes the person to high BMI levels, which we also wish to study. Like if you just think about it, like I could set up 100 genes that all have different exposure connections, all to the same outcome. And we're somehow saying embedded in this one world, all those randomized studies are supposedly valid and going on at the same time, So there may be a third gene, which basically just predisposes you to the outcome. We know that this BRCA1, BRCA2 exists. So people sometimes have a high risk of breast cancer. Well, so you could be born with, I have the high vitamin D gene. Okay. That is going to be protected. But if I'm born with the BRCA1 gene, what is that gene going to do for me if this gene exists? In the Mendelian study, if you're just focusing on this randomization and say, yeah, but at that moment, all these other very important things also going to predict the same thing you care about, you need to know about it. And then the epigenetics idea, the study of how your behaviors or environment can cause changes. Start with the gene, but how you live, the environment you're in, suggests what activates a gene matters as well. And a lot of theory about you have this dormant gene, then you get a virus, and then the virus activates the gene, and all of a sudden all those bad things will happen to you. But if you never got that virus, you never would have had the bad things. It's like, we talk about the autoimmune diseases and stuff, like what activates the autoimmune disease in the person? Well, it's maybe, well, hopefully not, but maybe it could be COVID or something. I'm trying to say maybe something like, getting some type of virus gives you the risk. The point is, as all people want to do, people try to simplify a question by saying, let's just look at this vitamin D gene in breast cancer, and we're going to have this nice Mendelian randomization. But when you step back, you say, there's a lot of complexities going on. So that can help with a part of the problem, but don't ignore all the other things that are really going on. So now, how do we assess causality using Mendelian randomization? So the genetic trait, yes, no, having these alleles can be used as an instrumental variable, and we'll use instrumental variable approach to assessing the potential causal effect. Oh, for those of you who are still on the call, the question for the CME credit had to do with Mendelian randomization protects you against reverse causation. So I wanted to say those words out loud because if at the end of the talk, you say, what was, I don't even remember he was talking about any of this. That was the question. Don't get that wrong. Okay, because that's like the one learning question. Reverse causation is, because I honestly believe that's absolutely true. There's no way I'm going to think that getting breast cancer at age 50 caused the gene 50 years earlier to occur. So that's the one thing for sure we don't have to worry about, is my mind. Okay, so instrumental variables. This is you hear this technique, but an instrumental variable is something that can be used to control for confounding and measurement error in observational studies. So this is a technique, this is not specific to Mendelian randomization, it's just a statistical technique. So to oppose X and Y of the exposure, vitamin D, and outcome breast cancer. And we can observe the relation to a third variable, your gene, okay? So that's what we're saying. We have like exposure, vitamin D levels, outcome, breast cancer, and genetic variant, Z. If Z is associated with X, meaning Z is linked to vitamin D consumption, which we think it could be because it's the gene for vitamin D levels, but not associated with Y except through its association with X, meaning that it's not a gene that also predicts breast cancer. It's really just a gene for vitamin D. If that exists, Z would be called an instrumental variable. That gene is the instrument. That is, an instrumental variable is a factor that's associated with the exposure, but not the outcome. So by definition, Mendelian randomization uses an instrumental variable approach to examine causation. So that's kind of neat because people try to use instrumental variables, but in real life, to try to think of something that's only linked to the exposure and not to the outcome, you get really, it's hard to find other instruments, but this could work. You know what I mean? Especially if the genetic world can show that. You know, we've looked at it over and over again. This gene is not a causative agent for breast cancer. So let me just walk you through this. So now, the assumptions for Mendelian randomization, and the genetic variant must be associated with the exposure. So the gene has to have some link to the exposure. And so the gene has to be predictive of vitamin D levels. And I've read online 5 times 10 to the minus 8 is like the p-value for exposure. They say, you know, this gene doesn't have a p-value of that level of magnitude. We won't call it a gene to predict. So that does seem like the literature is saying we set the bar pretty high. We're not just going to choose 0.02. We're going to choose 0.0. You know what I mean? This is going to be pretty significant link to the exposure. Assumption 2, the genetic variant must not be directly associated with the outcome. So I still think that's harder to prove because in this sense, the genetic variant is going to be linked to the outcome when you look at it graphically, because we're going to assume that if vitamin D is linked to the outcome and this is linked to the vitamin D, you would see a relationship. But this is, again, I'm going to trust the genetics people to say, we understand what these genes do, and there is no way that this variant is directly associated with the outcome. And finally, the genetic variant must not be associated with any other measured or unmeasured covariate. So it has to not also be at the same time having multiple potential connections to other traits. These things can still exist, but this is the beauty of it all. You know, the confounders could still affect the exposure and the outcome, but because what we're gonna do is look at sort of this pathway. This is I guess I say the beauty of if these 3 assumptions are met, you can make a causal argument about is the gene, which is now linked to the exposure, which means in some ways the exposure causes the outcome. Now, this pleiotropy, and I think I said it right, I hope so, pleiotropy. Assumptions 2 and 3 on the previous slide are related to pleiotropy, meaning that, you know, the relationship between measured confounders and the outcome. And the idea is, the idea that the notion that genetic variant may influence more than one exposure to outcome trait. It's only an issue if the particular gene influences the outcome, or if the additional trait also influences the outcome. And what I mean, for example, is like if I had this genetic variant that influences vitamin D and eye color. Okay, so maybe there are 2 traits that this one gene allele predicts. And eye color was not associated with breast cancer or vitamin D level. You know what I mean? It's like it's like, you know, it would be okay. So it's like the idea is if you know, as long as this sort of yellow line doesn't come down and say, eye color is also going to predict your breast cancer risk. So the idea is that the gene, the allele, doesn't have to have only one function. It just can't have a function or relationship to another characteristic that we think is along the pathway to their outcome. So I'm just trying to say, so the bar is not to say that, you know, every gene that's used has to have only one trait, but it just has to make sure that the trait, you know, is not along this pathway. So how do we calculate the causal effect? Now this part, because I know I'm already at the point where people should be asking questions shortly, maybe already. I don't want to spend much time about, because this is a math issue, but there's just what you can do. There's 2 common approaches, but there's actually a handful of approaches. But the first is to do what they call a 2-stage least squares regression. So TSLS, you might see this notation. Stage 1, the exposure is regressed on the genetic variant. So we want to see basically the relationship of vitamin D to the gene. That was that picture I showed where they had the BMI levels and the actual BMI. Okay. Next, the outcome is regressed on the predicted values of the exposure. So you take out of that model, you get the predicted values, and you plug them into the outcome, and that's what's going to be used. So you get, the predicted values from this model get plugged in and looked at. Now we have that they're the things that will now be used, and the outcome is like, did the person get breast cancer, yes or no, using the predicted values from this model of exposure on genetic variant. This gives a difference in outcome per unit change in a genetically predicted exposure. Basically, it gives a beta coefficient that represents for the predicted exposure level at a different, for each genetic level of the allele, I guess, you get a predicted, rate or a breast cancer or not. So I want to say, this is one of these just, oh, by the way, the variability estimates when you do this need some sophisticated math to be done correctly. So don't just do proc reg and SAS twice and assume that everything's fine. You know what I'm trying to say? There's going to be a little bit more to that. Okay, the other one we've talked about, I've seen, is this thing called the Wald estimator, which basically says you start by you get the genetic variant. You basically say the genetic variant on the outcome equals the exposure on the outcome, this relationship, times the genetic variant times the exposure. So basically the saying is like you have a coefficient that tells you what the relationship of this is, what the relationship of this is, and that's supposed to represent this relationship. And so basically it comes out to say that the Wald estimator is a ratio of two estimates, the genetic variant on the outcome, this whole thing here, divided by this part of the relationship. And again, intuitively, it sort of makes sense. You know what this reminds me of? Mediation analysis, if you ever think about it. I mean, it's very common to how we set up a mediation analysis. You have the variable, you have the mediator, and you have the outcome and so forth. And you sort of have what's the relationship with the exposure to the mediator to the outcome, and then the exposure directly to the outcome. And you're looking at how much of the overall was explained by each of the two parts. So it's the same mathematical idea, and it's this idea of a ratio, which in Wald is just a ratio estimator. And the limit, and one of the limitations, genetic variants do not always have large effects. So we said they have to be predictive, but they might have small effects. So they may be related to the exposure, but the magnitude of the effect may be not large. So that's to detect impact, may need very large samples. So I want to, and I'm really at the end, and so this is just to show you a recent study, 2020, alcohol consumption and cardiovascular disease, a Mendelian randomization study. So they took 94 SNPs to create an alcohol consumption instrumental variable. So 94 different genes combined. This is what they found are related to, turns out, a gene for alcohol consumption. And they found out that genetically predicted alcohol consumption. Again, that's what I was trying to say. That's the subtle thing going on here. It's not, when they actually look at the final model, it's not how much did the people in the study drink, it's what was their genetically predicted alcohol consumption. What did the gene, those 94 SNPs, predict your level to be, not what did you actually drink, okay. And basically, so that variable was consistently associated with stroke and peripheral artery disease and so forth. But it was, it was some evidence with coronary artery disease. And so this nice figure, so why I want to show you this is there's a couple quick things. The SNPs associated with alcohol consumption at genome-wide significance in 941,280 European. So this is not like the study of the 30 of us. They went out and got this enormous biobank data set, looked for what SNPs were associated with alcohol consumption at the genome-wide level, in this huge genomic GWAS analysis. So that's assumption 2, that genetic variants are robustly associated with the modifiable risk factor. These 94 SNPs they found, they say, were reliably correlated with alcohol consumption. Genetic variants are not associated with any confounding factors. So again, they just say that. But I mean, I think it could be true. But again, these 94 SNPs, to really arguably say they had nothing to do with anything else is hard for me to believe you can prove that. But arguably they did. And assumption 3, this instrument, these 94 SNPs, did not have anything to do with stroke or any of these outcomes. So that's what. Now, so they have alcohol consumption, and then they have, these are the outcomes. But what I want to, so just I'm going to show you. So they present this data, and they show that, hey, if you have, so it's kind of funny. As you increase the number of drinks, you have a higher risk of stroke. But remember, that's not actually like real drinks. It's like this genetically predicted value of drinks. And it's a nice paper and so forth. But what I'm gonna just jump to the, you know what's missing? In the end, they never actually tell you how old the people with the old, the highest gene or the middle gene, the low gene. They just say, hey, the high gene profile people have more strokes. And I'm like, yeah, but shouldn't we still care if they all were 80 and the other people were 50 or something? I mean, it just seems like my head was blowing up. It's like, you really can't, you're not going to tell me anything about, I mean, all the, there was no table one as we would think of a table one. It was, the data was really just this. I mean, they just show you, they tell you how they got the SNPs, and then they show you the result. And then you just have to believe that the gene risk of alcohol consumption is all that matters, because they won't even tell you anything else that matters. I'm like, and it's possibly because they don't have, all they really have in these enormous databases is the GWAS information and did the person have a stroke, you know what I mean? And some some level of alcohol. They didn't really do a randomized, didn't do a observational study, but it's still like, I think this, what do the groups look like with and without the SNP? I guess it just blew my mind away that I couldn't be confident that age had, supposedly there's some, they say, well, we can throw an age covariate in there or something, but they have such minimal information about, if I found out everyone with the high gene had some other set of characteristics, I wouldn't care that they had the gene. I said, stop talking to me about the gene. Do you understand this? All these people, have, I don't know, or have BMIs of 45. Well, really, do you think that gene of alcohol is not, overshadowed by the BMI of 45? And I know, whatever. So I think that's one thing. It's not shown. We have to just learn about all we get in this paper. And I had to go to the appendix, the online thing, is to find out where the data came from. The alcohol consumption came from the GWAS and sequencing consortium, smoking information, because they did see that. So one thing they did show was that, smoking attenuates this. And they said, oh, well, maybe you have to be careful because maybe smoking might be linked to the same SNP. So they did show that. But anyway, and then they had some education, but I still can't figure out, where they actually used this information, because they never showed you in the outcome necessarily education levels. So that's a brief overview. Hopefully it gave you enough to understand a little bit about Mendelian randomization. It's a useful approach. It's a good tool, but it won't solve all the problems, and could be useful in combination with other approaches. Thank you.
I'm going to see if there are any questions in the chat. Okay. Anybody in the audience with any questions?
Can you go to the last?
The last
yeah,
slide.
sorry.
Yeah.
The code. There you go.
Oh, the code. Yes, yes. Put the code in. I won't say it again. I always gave you the answer though, so
I have a question, Dr.
Yes.
Dyson. So in the world of cardiovascular medicine, we think of diabetes, coronary disease as polygenic polygenic diseases, and that's one of the challenge in genetic research in cardiovascular medicine. And if you believe in linkage, and if you believe that cardiovascular disease are truly polygenic, and if linkage exists, I'm not sure if the first law of Mendelian genetics, which is the law of segregation, is entirely true.
Well, yeah, exactly. No, I'm going to agree with you, because that's obviously there are these assumptions, but I just think as we are getting more and more understanding of, you said, the complexity of how multiple genes simultaneously affect outcomes, and and how one gene might affect more than one outcome. I think that Mendel's laws that he put together were, what appeared to be, the way it would be, the way the world would work very simply would be the way he put it together. But I think we found out that it doesn't work as simply as that. So you're correct. I think that, so that makes this type of research challenging. I think it still can be helpful, but I think the point is that other than agreeing with you, I think I don't know what else to say. You know what I mean? That I think it does create a challenge, because we don't believe, or we are likely not to believe, that, you can really do something and say that, I can find the gene for heart disease or something.
Right. And in the world of randomization, the goal is to eliminate known unknowns and unknown unknowns.
Yes.
And I'm not sure if Mendelian research achieves that purpose. So anyway,
Yeah.
we can talk
Well,
about
no,
it.
I mean, and this is so I want to say, and again, I came to you to present this talk as Greg said, hey, could you talk about Mendelian research, randomization?
Mhm.
And I honestly, Greg, before you said it, I was like, well, I better start Googling this right now. I mean, no, but you know what I'm trying to say, but the point is, I wouldn't say that I myself have not published a paper using this methodology. I've certainly seen it and understood it to some sense, and now I understand it much more. I think that it does have some, to me, it's just another tool that would help, this study on vitamin D in breast cancer using Mendelian randomization approach, in addition to well-designed observational research studies that use statistical methods like propensity scores to balance, in addition to maybe some randomized trials that actually give vitamin D supplements to show there is some incremental effect on outcomes. All of those things together are how we can understand, like, what does vitamin D to breast cancer. It's just that I don't think this by itself could solve the problem,
Right.
but it should contribute some information. And the idea of the measured unmeasured confounding being controlled, again, at birth, it's again, because the outcome is so far offset from birth. That's why I think to me, that's the fundamental challenge is, like, when we say that in the randomized trial, we achieve balance, like our table 1 looks good, we don't think the table 1 was measured today and the outcome was measured 50
Right.
years later. We think the table 1 and the outcome were actually measured in close enough proximity that we think that table 1 meant something. You know what I mean?
Right.
And I think that to me is where the genetic argument, every year of life, so much environment and so many other things begin to impact.
Right.
Yeah. So I agree with, again, what you just said.
All right.
Yeah.
Just quickly, thanks so much, Ralph. This has sort of been the second talk in your statistical series for us. And,
Yeah.
maybe we'll get you back and talk about propensity scoring and some things like that. I think it was really important to distinguish intervention
Mhm.
versus exposure.
Yes.
And, a lot of things we, as cardiovascular medicine or surgical specialists, we practice based on guidelines. And one of the things this sort of reaffirms, we look, if there's a level 1 indication, then we go level of evidence, A, B, or C.
Mm-hmm.
This type of information may not, Mendelian randomization studies really won't fit into that based on that.
Well, I mean, and that's my intuition as well, because it seems hard to think, again, that you would have a gene that predisposes you to get a particular stent
Correct.
versus not. So I think you're right.
So the question is, though, but what about, has this research and outcomes from it worked its way into primary prevention strategies and risk assessment? Did you come across?
I've not seen that, but at the same time, I think, well, here's the thing. Almost everything I've seen in Mendelian randomization studies is trying to either confirm or not confirm a finding that's already been found. Do you know what I mean? I haven't seen it yet as a discovery method. So in some sense, it's diving into, everyone keeps talking about vitamin D and, this outcome. Everyone keeps talking about alcohol and this outcome. Let's look at what the Mendelian, and sometimes it says, you've been wrong, or, the genetic relationship doesn't seem to exist, or, hey, I do see evidence that, BMI and systolic blood pressure are impact, it's related. So I think, Greg, it's still, at least in my evaluation, it's being used more and more. It's being used with these huge databases, which again, to me, provide a particular piece of information, but it's hard to trust that all by itself is like going to make a whole policy decision off of that type of paper. But it's again, it supplements a thought that already existed. You know what I mean? I haven't yet seen someone go into the genomic world and say, nobody's ever thought about a gene that causes, eye color leading to cancer. And now I'm going to show it worked. You know what I mean? No one's like, so that's why. So to my long-winded answer is, I don't think it by itself is leading the policy, but it's probably contributing in levels of evidence, because it can either add more evidence to or detract evidence from, take away evidence from. So therefore, I do think it is impacting level of evidence decisions, but as the second or third in line of analysis, not necessarily the first in the line. Now, maybe someday it will become the first in line, but I haven't seen it there.
Thank you.
There was a question in the chat.
Oh,
Dr.
okay.
Wieser.
Can you guys hear me? I can maybe ask that question a little bit.
Yeah, go ahead, Jose.
Go ahead, Dr. Wieser.
Yes, thank you, Dr. D'Agostino. I think it's very interesting. I'm trying to understand a little bit about for me, randomization, as you said, is something before you design a study. But it sounds to me that it is also interpreted as more of analysis. So you're looking at, okay, what genes came in. So obviously you didn't randomize what person was going to get what gene. So obviously it's something, as you said, a conception of the patient. My question is, and I initially thought, or at least as you were discussing that you wanted to have equal numbers on different groups. I think that happens to us as well as when we're deciding clinical trials. And I thought this was where this was going. And again, I'm trying to understand whether this is applicable to this or not. But for instance, we're starting to design a clinical trial, and the question we have is, well, I want to do an intervention, but it's a multi-center study. So this intervention may be done differently in San Francisco than in Richmond or in Philadelphia. So maybe one, we can call it a pseudo allele, I guess, would be the location, right? And then we want to know, ideally, we would like to make sure that at the end of the study, I end up with people that are overweight in one group, on the treatment group, and skinny on the other. Or I have too many males or females. And for instance, in my case, because I'm looking at different PVC burdens, a burden of extra beats, I actually have decided to do a randomization between a stratified randomization, which I say, well, if the PVCs are more than this, then we're going to use that treatment. Or we're going to have a different randomization. If it's below this, they're going to have a different set of randomization. So it's kind of stratified randomization, but I'm wondering if...
Yeah, what you're describing, if I'm hearing it correctly, stratified randomization is what you would have to be doing, stratifying both within the clinic. If in fact the intervention could be implemented differently based on location, you probably do need to make sure that within each intervention site, clinic site, that there is balance. And the challenge with the other covariates, weight and height and other things like that, it's hard to have too many levels of stratification in a trial like that, but you could still create a second or additional strata level variable for the randomization. So the idea being creating balance within a area, and again, except for the genetic idea, that would have been like saying that, getting people from different ancestral descents from North America, South America, Africa, and Europe, you'd have 4 different groups, and then look at the genetic Mendelian randomization in each of these 4 regions, because there would be more homogeneity. Well, it's like looking at San Francisco, Chicago, Boston, and Virginia as 4 different sites and do the randomization within. That's the same simple idea. The question that was online, you do need genetic information to do Mendelian randomization. Fundamentally, you'd have to know the SNPs and the alleles, and you have to have the genetic information on the patient, because that's how you determine what group, quote, they were randomized to. Because the whole point is you're saying, again, that the thought is that they were randomized when they were born. God put them into a group at conception, and you want to figure out what group were they put in, but you can't figure that out unless you know the genetic information. So this does put a burden on those types of studies as well.
Thank you.
Great.
All right, sounds good.
Thank you,
everyone, for joining.
Thanks, Rob.